So I have the pleasure to introduce Dr. Loeffler. She's already been such an active, helpful contributor to the case already, but also just want to go through her formal introduction here. So Dr. Ann Loeffler is a pediatric TB expert based in Portland, Oregon, where she's now Multnomah County Deputy Health Officer after working as a pediatric infectious diseases attending, as well as physician leader at Randall Children's Hospital for almost 20 years. In 1997, Dr. Loeffler joined the Curry International TB Center training faculty, and she continues to serve as one of the center's Warmline pediatric TB medical consultants. She was the editor of the first edition, as she's mentioned, of the Drug-Resistant Tuberculosis, a Survival Guide for Clinicians, and has continued to contribute in each subsequent edition. In 2018, she was recognized as one of 10 CDC US TB elimination champions. And she's currently a member of the CDC Advisory Council for the Elimination of Tuberculosis. So in addition to her incredible background there, I also just want to say how personally grateful I am to all of the kind and patient guidance she has given to me in some of our challenging pediatric cases, much as you can see her valuable contributions during our case before. So I'd love to turn it over to her for her presentation.
Thank you. You are too kind, and just know that this is it just makes me happy to know something about something and be able to share. So please don't ever consider it to be imposition or anything else. And if I ever, anyway, please call me because it makes me happy. And in Oregon, people are comfortable calling me Ann. I know that Washington, Seattle in particular is a little bit more formal, but I go by Ann if you're comfortable. So Lana asked me to give this talk after one time I sort of reminded people on this call to make sure to examine and review systems and symptoms on kids who are exposed to TB or who have positive immune tests. So that was the basis of this talk. So Lana, are you able to show the slides, please?
Yeah, and MJ can show them on our end, or you can advance them yourself. Oh, but yep, looks like MJ's got it. Great. Oh, keep going.
Okay, so let me just see if I can make my sides a little smaller so I have more room. Okay, so this is just intended to be a reminder about how to evaluate children for latent TB infection in order to avoid missing, especially extrapulmonary TB. Next slide, please. Oh, I can advance it myself. Let me try that. Not advancing, but so could someone else advance? Thank you. So these are just the learning objectives, in particular for those people who are looking for CE or CME. Next slide, please. Again, I know this is going to be a reminder for most of you, but sometimes reminders are good, and sometimes people, don't take care of as many pediatric cases as I have. So in the United States, most children are actually recognized as having TB disease during a contact investigation. And so a bit more than 50% of kids with TB disease are actually asymptomatic. So when someone calls me and they say, their x-ray shows this, but they don't have any symptoms, I'm like, yeah, and that's true. So it is the enormous blessing that we have in the United States and in many Western places that we can identify kids before they are symptomatic. And that should not dissuade you from considering that diagnosis. And additionally, it's a weird feature that in pediatric TB, you can have very extensive radiographic changes and the child sounds completely normal on auscultation. I don't know why it is, but if you had extensive disease on let's just say a 4-year-old who has pneumococcal pneumonia, you would hear the classic rales and decreased breath sounds, but you can have very extensive TB disease and listen and you're like, these breath sounds are normal. I swear they're normal. So that's actually a key feature that I use when I'm considering what the diagnosis in the context. Within the spectrum of ages in pediatric tuberculosis, infants and adolescents are much more likely to have both signs and symptoms. Next slide, please. This is just a little slide that I stole a long time ago from Jeff Stark, who's one of my good friends and colleagues in pediatric TB, as a reminder that unlike adults or teens who have reactivation TB and more typically have radiographic changes in the apices, children can have they're parenchymal abnormalities anywhere in the lungs, and 25% of the time it will be in more than one lobe. And in correlation with that, they much more often will have swollen intrathoracic lymph nodes. And if you did CT scans on all children who are having that sort of primary presentation, they were infected relatively recently and their TB disease has progressed, you know, maybe almost all of those children would have a visualized mediastinal or hilar or paratracheal or subcarinal lymphadenopathy. But when people have done studies of just plain films, people talk about between 30 and 90% of kids with TB disease in their chest will have lymph nodes. It depends upon how sort of aggressively you read it, and sometimes you have to squint really hard. That was a joke, and hope you're laughing. But most importantly, you need a lateral view to sort of have that suspicion and also confirmation that a fullness or a shadowy look on a frontal view is in fact a 3D structure, which represents lymphadenopathy. Cavitation is rare in children, except for adolescents. And as I mentioned already, it's not uncommon at all for a child to have no symptoms or very mild or non-specific symptoms when they have TB disease. Next slide. So in terms of the reason that we are talking about this situation today is a reminder of extrapulmonary TB. And people talk about children having more extrapulmonary TB than do adults. But if you look at this slide, which comes from the CDC 2021 data, 21% of all ages of patients actually were submitted through the, you know, what's the RCTV, RVTC, presuming some of you smiling at that I can never remember those letters, have exclusive extrapulmonary. So they might have lymphatic, which could be intrathoracic or peripheral, like a scrofula. They could have pleural disease. They could have bone and joint, peritoneal, and then of course other. Next slide, please. So that was all ages. I looked at a number of studies which looked at pediatrics in particular, and it seems like they all start with the paragraph, children have more extrapulmonary TB. But honestly, when I really looked at as many studies as I could find and also compared it to that CDC data, I don't know that it's that different in terms of exclusive extrapulmonary disease. So here's another thing that I thought was important. When people compared pulmonary and lymph node TB, what people noted is that outside lymph nodes and lungs, other forms of TB disease in children had lower rates of TST and IGRA positivity. So of course, then the way that you'd have to confirm that is by culture and, you know, usually by biopsy. So I thought that was interesting and something to take note of, and adds a complication to the diagnosis for sure. These are some numbers in general. Up to 2/3 of the cases of extrapulmonary TB are considered to be lymphatic. Next slide, please. This is a more recent Turkish study. That last one was a sort of meta-analysis that I saw maybe 10 years ago, but this is more recent. And this is one Turkish center. They looked over a 10-year period. Unfortunately, they did not give the denominator of how many kids with TB disease that they had, but they noted this issue of high rate of TST or IGRA negative. But they also had a low rate of culture confirmation. So that makes me suspicious. You know, if you have a negative TST IGRA and you don't have a positive culture, you know, you're based on, you have a clinical suspicion that it's TB or granulomatous changes, and that can be caused by other things. You know, kind of alluding to that first case where people talked about sarcoid, which is a cause of non-casein granulomata. But among 70 kids that they had, they talked about a third had scrofula, a 14% musculoskeletal, 13% GI, 11% miliary. You see kind of the proportions, and I think that's all you can really make of that. Next slide, please. This was a Spanish study. I guess I would think in general that in Western Europe, they have very careful, and in Spain in particular, there's a lot of people interested in pediatric TB. Now, it was interesting here that they did not consider intrathoracic lymphadenopathy to be extrapulmonary. So they were only looking at what they considered to be extrathoracic. And interestingly, and this is the first big difference in TST versus IGRA that I've ever seen like this, they found a much higher rate. I'm sorry, I have that a little backwards. The way that they phrased it, they had 22% were less than 5 millimeters TST. So that actually is close to about the 77% of the positive IGRA. In this case, they had 2/3 of the kids were culture confirmed, which is much higher than that Turkish study. And 72% had only one extrathoracic focus versus 28% had disseminated. And I'd love to, have you all think about, and if there's time, talk about. It feels like since I've been involved in the care of more adults with TB in my new role, and with my old friend Lisa Ferguson, who's now a nurse consultant for Washington, which you're very lucky, in case you haven't met Lisa already. But when we're taking care of patients with extrapulmonary TB, it feels like we were seeing a lot of adults with disseminated disease, even with miliary changes, compared to in kids, it was relatively common to just have that one extra thoracic focus. So I don't know if that's one of the differences between peds and adults. But in any case, in this study, you can see a distribution. They scrofula was the most common extra thoracic site, and about the same number of musculoskeletal. They had more CNS disease, less gastrointestinal, but sort of everywhere, everywhere in the body, basically. Next slide, please. So kind of going again to the reason that I think Lana asked me to give this talk, if you look at the national guidelines, so this is the NTCA document, and if you don't have this, go on their website and you have to sort of download it so that they and sign in, because they want to be able to tell you, they want to be able to push out to you if they do updates. So it's a really nice resource. But here's what they say. A patient with a positive test result for TB infection should be evaluated for active TB disease before starting treatment for LTBI. So they talk about a clinical evaluation, including a medical history, symptom review, focused physical exam, as well as chest radiography. And then, of course, they talk about bacteriology. It just seemed to me that in some places and in some situations that I've tried to be helpful as a consultant, sometimes patients just get an immune test, either a TST or an IGRA. If it's positive, they get a chest radiograph. Maybe they get a mild symptom review, like do you have cough, fever, weight loss, hemoptysis, night sweats? But if the answer is no and the chest radiograph is normal, you go on to LTBI treatment. And I'll show you in a minute some situations that I've been involved with where that, basically was a failing for that patient. So what I'm trying to encourage you to make sure that you're doing, to as much extent as humanly possible, is, especially for pediatrics, but heck, why not for adults, medical history, symptom review, focused physical exam before you start LTBI treatment. Next slide, please. Oh, look at that. I put a circle around it. Next slide, please. So this is the American Academy of Pediatrics Red Book. This is our sort of our Bible in pediatric infectious diseases. Basically the same thing. Your assessment should include asking about symptoms of TB disease, which is, again, more extensive than those top 5 questions if you want to know about extrapulmonary disease. So I talk about lumps and bumps in the neck. I talk about pain in the back, in the extremities, in the belly, in the head. I talk about mental status changes. I talk about growth. I talk about, playfulness, etc. And then a physical exam for signs of TB. Next slide, please. Next slide, please. And this is a guide that CDC put out for primary care physicians. I'd say a little more practical. So instead of emphasizing a physical exam, which has at least been alluded to in those prior 2 documents, they talk about a symptom review. And next slide, please. Sort of when I teach people who don't do tuberculosis, I encourage them to think about the fact that TB can infect any tissue in the body. So, just starting at the head, the brain, the meninges, the ears, the mastoids, and then ... I'm reminding you any part of the body. So I have a request of you in the chat, type a body part that TB can affect. I love it. I love your questions. Good job. Keep it up. More body parts. Yay. You make me happy. Okay, next slide, please. So now in the chat, type a question you would ask a patient to see if they might have TB in that body part. Back pain, love it. Any pain, right? So instead of listing every body part, I say, does anything hurt? Their head, their arms, their legs, their tummy, their bottom, their, every body part. Yeah. Unusual sensations. I like it. And eyes are really tricky. I don't know if I'm speaking for everyone on the call, but I find ocular tuberculosis to be so challenging. Next slide, please. So, these are kind of good. I like that. Any changes in hearing. Now, just an FYI, little, board type level test. If you have middle ear tuberculosis, the classic finding is painless ear drainage. So painless, that's, hard. But anyway, so these are the questions. If you literally can't arrange a physical exam, if you're talking to someone who really knows the patient or is the patient, if you ask these questions, you're gonna get some good thoughts. Now, it's hard with like immigrants and refugees who sometimes are fearful that some of these questions or identification of TB disease might preclude them from moving ahead with that process, but you really have to give people permission to tell the truth. Okay, next slide, please. So these are a couple kids that I could think of off the top of my head. So this young lady was found to have a 16 millimeter TST. Her chest radiograph was normal, and she was started on INH for LTBI. So I'm asking you the question in your mind: is that all? Are you going to tell me if she had symptoms of extrapulmonary TB, that someone examined her? Of course, when people think about examining someone for tuberculosis, they think about listening to their lungs, but that's like the one thing that's covered, right? Your chest radiograph should tell you whether they have parenchymal disease, intrathoracic lymph nodes, or pleural disease. So it's kind of the one thing you don't have to do. But of course, the heart, I don't know if I saw on that list, the heart is important. And, but again, theoretically, you'd see heart enlargement. Next slide, please. So, she started on isoniazid, and then sometime later, like a handful of weeks later, she shows up at a community emergency department, and she's got a tender chest wall. And I think at that first time she was seen, they didn't see much. They said, come back or go to your primary care if it gets worse, it doesn't get better. Well, over the course of weeks, she develops a fluctuant mass. Well, this is a handful of years ago when we had more MRSA, which obviously causes abscesses. So, and they did not seek a translator, is what the family told me. And so, a provider in the emergency room just slashed open the mass, and they said, you have an abscess, and they treated her with antibiotics, but the cultures were negative for staph and strep. Well, if you've ever slashed open a pyogenic infection, those cultures tend to be positive. So, did someone think, wonder why those cultures were negative? In any case, of course, the mass recurred. Next slide, please. And she went back to the PCP. The PCP started to put it all together. They ordered more imaging. They collaborated with public health, and she was eventually found to have rib osteomyelitis. Now, she'd been on isoniazid for quite some time, and so I collaborated with my surgeons to kind of clean out that abscess site and biopsy that bone. And unfortunately, it was culture negative, but we treated her for TB disease and it resolved. So I'm liking to hope that if you'd used a translator and you'd ask those questions, like, does anything hurt? And you waited for a response, hopefully you would get an answer. But, sometimes people have aches and pains and they don't kind of volunteer it. So I do want to leave space for that. Next slide, please. Here's another young lady that we took care of. This young lady, I don't remember, but I'm saying she had a 16 millimeter TST. Her chest radiograph was normal, and she started on INH for LTBI. And again, nowadays you're thinking, is that all? Next slide, please. So unfortunately, this was a horrible situation where part of her family during the refugee process was sent to Australia and part was sent to the United States. This was a very tight-knit group, and she was very depressed. And she took her whole bottle of isoniazid all at once in an effort to kill herself. So a little off track, another board level question. What happens when you have isoniazid overdose? I'm looking for the chat to blow up. What happens to a person who takes their whole bottle of isoniazid, and what do you do about it? So Lana did not say I could talk for an hour, so I'm gonna tell you the answer. And the answer is, if you take a whole bottle of isoniazid, in fact, even if you only take about like 15 or 20 pills, you will start seizing. It's a refractory seizure that does not respond to the typical benzodiazepines that we used. And so just like someone said in the chat, woohoo, gold star, you have to use IV pyridoxine, vitamin B6. And unfortunately, not all hospitals store that. Okay, but I digress. She was switched to isoniazid and rifapentine with monitoring so that she could just take her drugs once a week and not have a whole bottle of isoniazid at home. But remember, we still hadn't ever addressed that, that she wasn't screened for late extrapulmonary TB. Next slide, please. So she was seen in the next weeks by OBGYN for chronic pelvic pain. And she underwent laparoscopy, and she was found to have diffuse female genitourinary tuberculosis. And that's FGTB is what we're liking to say for this disease. And unfortunately, this is a disease that leads to very frequent infertility. Now, she had already been on LTBI treatment a long time, and cultures may not have been valuable. So what I like to do in this circumstance is hold all the meds for a handful of weeks. And so they did that, and they rescheduled her surgery. But unfortunately, all the specimens were dropped into formalin, which kills tuberculosis and really every other bacteria that I know of. And so this is just another one of those like key point reminders. If you're going to do cultures, biopsies for tuberculosis, you will have to ask them 3 or 4 or 10 times to make sure to send it in a sterile cup, not in formalin. Next slide, please. So her belly pain resolved, her disease did well, but it is unfortunate that it's unclear if she would ever be able to successfully conceive or carry a child to term. And I don't want to say that if we had identified it, during her LTBI initiation phase, if that would have been different. But what I like to think about when I think about patient safety and error prevention is that we want to do it right every time, even if it's possible that the sort of error that was made, didn't lead to the bad outcome. So that's why I'm encouraging you to really consider the possibility of extrapulmonary TB before you start TB treatment, LTBI treatment. I see if pelvic pain picked up early, will pelvic ultrasound be helpful? So honestly, this is a very complicated topic. I recently gave grand rounds with some folks for the OHSU team, and Sylvie's has fellows who are very interested in this in Washington, and they would be a good source of information. Sometimes the ultrasound is helpful. Sometimes the CT is helpful, but sometimes you have to do a hysterosalpingogram to put a dye or contrast, up into the fallopian tubes, and sometimes it requires laparoscopy or endometrial biopsy. So this is a very tricky topic. I don't want to undersell it. Next slide, please. So in conclusion, ideally, Chandler's here. I'm going to have can Chandler chime in, or let me finish real quick. Ideally, every person should have a history and physical exam before LTBI treatment is started, but at least a thorough symptom review, and in children, a recent exam looking for growth parameters and general affect, because sometimes it's just the appetite starts to tail off, the weight plateaus, or the TB meningitis is actually very indolent, so sometimes just not as perky. So ideally in pediatrics, you'll get more information than less. but a very high index of suspicion if any symptoms concerning for extrapulmonary TB. So I think that is my last slide. And I am more than glad for Chandler to chime in as they are becoming a regional expert for FGTB.
Great. Well, let me just, Chandler, before you jump in, I just want to say thank you so much, Anne. That was an incredible talk and so much information and pearls in there. Thank you for that. And so, yes, we want to open it up to questions, but it sounds like Chandler, maybe you can take it away right now.